Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers like you. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 114 of our Pharmacotherapy MCQ series, majoring in infectious diseases. Welcome. And the first question reads, Mr. KTM, a 36-year-old male injectable drug user or abuser, presents to your accident and emergency department with a body temperature of 101 degrees Fahrenheit. His chief complaint is chills, joint pains, which has lasted several weeks. On physical examination, systolic murmur is heard, and the echo shows moderate mitral valve regurgitation and a valvular vegetation on the tricuspid valve. And his blood culture grows Staphylococcus aureus. A skin test revealed oxacillin susceptible Staph aureus. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. KTM's treatment? Would you settle for A, Vancomycin for at least 6 weeks plus Rifampicin for at least 6 weeks plus gentamicin for 2 weeks? Or would you use vancomycin as monotherapy for 6 weeks? Or would you use nafcillin as monotherapy for 4 weeks? Or is it true that nafcillin for at least 6 weeks plus rifampicin for at least 6 weeks plus gentamicin for 2 weeks would be the best choice? I'll give you 10 seconds to choose the correct answer. I would settle for nafcillin for 4 weeks. Now, cure rates for right-sided Staphylococcus aureus infective endocarditis in the IV drug users are high. They are above the 80% mark, and they may be achieved with relatively short courses of either parenteral or oral treatment, which last anywhere between 2 to 4 weeks. Now, current evidence suggests that either parenteral beta-lactam or daptomycin short-course therapy is adequate for the treatment of uncomplicated methicillin-susceptible right-sided infective endocarditis, such as this particular case. Let's move to the next question, please. And the next question reads, Mr. JLS, a 55-year-old male patient, presents to your accident and emergency department with a body temperature of 102.4 degrees Fahrenheit. His chief complaint is chills and muscle weakness. He has no history of injectable drug use. And on physical examination, a systolic murmur is heard, and when an echo is done, there is a moderate mitral valve regurgitation and a valvular vegetation. Now the blood cultures slowly grow Cardiobacterium hominis. So my question to you is, which of the regimens listed below would be the most appropriate for Mr. JLS treatment now? Would you choose to treat him with vancomycin for 6 weeks or ciprofloxacin for 6 weeks? Or would you treat with ceftriaxone for 4 weeks? or do you choose to treat with ampicillin plus ceftriaxone for 4 weeks? I'll give you 10 seconds to choose the correct answer. I would settle for ceftriaxone for 4 weeks. I would like to start by saying that HACEK organisms, HACEK organisms, should be considered ampicillin resistant. Therefore, penicillin and ampicillin should not be used to treat patients with infective endocarditis caused by the HACEK organisms. Now, the HACEK organisms include Haemophilus species, Aggregatibacter actinomycetocomitans. Then there's also Cardiobacterium hominis, which is a pathogen in this particular patient's case. Then there's Echinella corrodens and Kingella kingae. Those are the microbes that form the HACEK group. Now, these microorganisms commonly colonize the human oropharynx as normal indigenous flora that could cause mouth infections. I'd like to remind you that HACEK organisms are most often associated with infective endocarditis, and they account for up to 10% of cases, and they may cause severe infections. Now, most of these strains of bacteria are susceptible to ceftriaxone and even to other third and fourth generation cephalosporins. That's why I opted for or settled for ceftriaxone in this particular case, and the duration of therapy for NVE is 4 weeks. It's reasonable in this particular case. So you can treat that valvular infection over a 4-week duration. Let's move to the next question, please. And the next question reads, Madam DMM, a 67-year-old female patient, was admitted for AMI at your hospital for the past 7 days. Today, she reports redness and tenderness at the peripheral IV catheter site. Half of the 4 blood cultures are positive for E. faecium, which is resistant to vancomycin but sensitive to each of the drugs listed below. They also grow E. coli, which is pan-sensitive. And this patient has been receiving heparin for the past 5 days, and her platelet count before heparin initiation was 200,000, and today it stands at 50,000. So my question to you is, which of the antibiotics listed below would be the most appropriate for the treatment of VRE in Mrs. DMM's case? Would it be quinupristin, dalfopristin? Would it be linezolid? Would it be daptomycin? Or would you settle for chloramphenicol? I'll give you 10 seconds to choose the correct answer. Daptomycin would be the best choice. Now, daptomycin, marketed as Cubicin, would be the most appropriate choice for DMM in my opinion. Remember, linezolid or Zyvox can cause thrombocytopenia and should not be added since DMM, as we have been told, already has a low platelet count of 50,000. Then quinupristin, dalfopristin, marketed as Sinacid, should not be used in DMM's case, since DMM can develop myalgia and arthralgia with therapy when using quinupristin and dalfopristin. Then chloramphenicol should be the last resort, since aplastic anemia is fatal and it's an adverse effect that can occur in approximately 1 in every 10,000 patients who receive it. Let's move to the next question, please. And the next question reads, Mr. STI, a 77-year-old male patient, develops native valve endocarditis, abbreviated as NBME, due to S. bovis, which has a penicillin MIC of 0.06 mics per ml. Currently, he takes amiodarone, lisinopril, metoprolol, warfarin, atorvastatin, glyburide, and aspirin. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. STI's treatment now? Would you treat him with vancomycin for 4 weeks? Would you opt for penicillin G plus gentamicin for 4 weeks? Would you settle for penicillin G for 4 weeks, or would you do monotherapy with ceftriaxone for 2 weeks? I'll give you 10 seconds to choose the correct answer. I would treat this case with 4 weeks of therapy using penicillin G via IV route. Remember, penicillin G or ceftriaxone monotherapy for 4 weeks is the preferred regimen for most patients above the age of 65. And if I remember well, this gentleman was 77, so he qualifies. And the addition of gentamicin to penicillin would shorten the duration of therapy, but it isn't advisable in the case of this 77-year-old gentleman because of advanced age. You'd fry his kidneys unnecessarily. And I would like to add that vancomycin is only an alternative for patients unable to tolerate beta-lactam therapy. Let's move to the next question, please. And it reads, your infectious diseases team has decided to initiate amphotericin B deoxycholate, that is what we call conventional amphotericin B, to a patient in your medical ward due to financial constraints. My question to you is, which of the statements listed below would be correct when administering this formulation of amphotericin B? Is it true that it directly binds to and inhibits 1,3-beta-D-glucan in fungal cell walls? Or is it true that if no contraindications exist, administer 500 ml bolus of normal saline before or after infusion to reduce the risk of renal toxicity? Or is it true that pre-medication with an NSAID or diphenhydramine is sometimes needed to reduce infusion-related reactions? Or is it true that should administer the total dose by constant IV infusion over only 30 minutes? I'll give you 10 seconds to choose the correct answer. So answers B and C are correct. It is true that if no contraindications exist, we should hydrate these patients well by administering 500 ml boluses of normal saline before and after infusing the amphotericin B to reduce the risks of renal toxicity. And it's also true that we need to pre-medicate them with an NSAID or diphenhydramine to reduce infusion-related reactions. Remember, amphotericin B deoxycholate, the conventional amphotericin B, should be used with additional IV fluids before and after. Because of that reason I mentioned, there is nephrotoxicity that can be curbed by hydrating. Then NSAIDs can be used to help minimize some infusion-related reactions. And I'd just like to remind you that the total dose of amphotericin B is best administered over 4 to 6 hours, not any shorter than that, because if you pushed it over 30 minutes, there would be those rate-related adverse drug reactions. I'd like to remind you that amphotericin B deoxycholate blocks ergosterol incorporation into the fungal cell wall, whereas the echinocandin antifungals such as anidulafungin, marketed as Eraxis, or caspofungin, marketed as Cancidus, and even micafungin, marketed as Micamine, are known to be 1,3-beta-D glucan inhibitors. Then liposomal amphotericin B, just for your information, is less toxic than this conventional form, but it's more expensive. Let's move to the next question, please. And it reads, Mr. PSO, a 57-year-old male patient who was admitted to a medical ward for treatment of diabetic foot infection, develops candidemia caused by Candida albicans. Currently, he takes metformin, glyburide, losartan, gemfibrozil, and pioglitazone. He has been receiving fluconazole since 4th of July 2020 and ertapenem since the 30th of June 2020. For this current infection, the final lab result or report for blood cultures was obtained on July 11th and it shows no growth. So my question to you is, when should Mr. PSO stop undergoing therapy using fluconazole? In other words, when should Mr. PSO's fluconazole therapy be stopped? Should it be on August 1st, 2020? Should it be on July 25th, 2020? Should it be on July 18th, 2020? Or should it be on July 14th, 2020? I'll give you 10 seconds to choose the correct answer. So it should be stopped on 25th of July 2020. Now the IDSA guidelines recommend that treatment for candidemia should continue for 2 weeks, 14 days, that is, after documented clearance, i.e. 11th July 2020 of candida from the bloodstream. Remember, we are told the culture was negative on 11th of July 2020, and this recommendation is supported by the low complication and even relapse rates when this duration of therapy was used in clinical trials. Let's move to the next question, please. And it reads, Mrs. MMM, a 57-year-old female breast cancer patient, develops systemic CMV infection. Currently, she takes warfarin, amiodarone for atrial fibrillation, and the consultant oncologist decides to initiate foscarnet therapy in Madam MMM's case, after consulting your infectious diseases team, of course. So my question to you is, which of the adverse reactions listed below would likely occur? Would you expect a thyroid storm, major bleeding, QT interval prolongation, or hepatotoxicity? I'll give you 10 seconds to choose the correct answer. So QT prolongation would be a challenge here. Remember, foscarnet use with amiodarone is contraindicated due to the fact that both of these medications increase the QT interval. Now, this is particularly relevant if the patient already has a baseline prolonged QT interval equal to or above the 450 millisecond mark. Now, it is also important to note that foscarnet has a unique mechanism of action compared to the other antiviral agents. It functions as a pyrophosphate analog, which can then work as an uncompetitive inhibitor of viral RNA and even DNA polymerase without requiring the activation by viral thymidine kinase. Now, this makes its use or makes it more effective in resistant CMV, which can sometimes occur in cancer patients because they are immunosuppressed. Now, unfortunately, its use is plagued with a number of side effects which can make it difficult to use, especially for patients such as this one, and it can also make tolerating it very tricky for such cancer patients. Now, while amiodarone and warfarin increase the risk of bleeding when co-administered together, the addition of foscarnet has no impact on this interaction. So, major bleeding wouldn't be an issue here. Then I would like to add that hepatotoxicity and alteration of thyroid function are adverse effects of amiodarone that are not affected by the use of foscarnet. So I would not consider D and A suitable answers to this question. Let's move to the next question, please. And it reads, Mrs. LOM, a 47-year-old female patient, presents to your urology clinic with a chief complaint of increased urinary frequency and painful urination alongside flank pain, which has lasted for the past 4 days. She has a past medical history of sickle cell disease and she's obese. She has no non-drug or food allergies. The consultant urologist is considering initiating therapy with levofloxacin at a dose of 500 milligrams orally once daily. And you are told the E. coli resistant rates in her community is 7%. So my question to you is, which of the therapeutic options listed below would you recommend as the clinical pharmacist specialist attached to the infectious diseases team at your hospital? Would it be vancomycin STAT dose? Would it be tobramycin IV STAT dose? Or would it be levofloxacin is sufficient alone? Or would you add a clindamycin STAT dose? I'll give you 10 seconds to choose the correct answer. Levofloxacin would be sufficient alone. There would be no need to add vancomycin, tobramycin, or clindamycin. Now, the IDSA guidelines for uncomplicated cystitis and pyelonephritis state that a one-time ceftriaxone dose and a 24-hour consolidated dose of an aminoglycoside should be used for patients with pyelonephritis when the fluoroquinolone resistance rates exceed 10%. Remember, our fellow here has 7%, if I remember well, in his community. Now, clindamycin and vancomycin should not be used as they are not known to provide clinically relevant coverage for E. coli. So that makes D and A automatically wrong. And I would like to add that moxifloxacin shouldn't be used for urinary tract infections since it has minimal urinary elimination, and there is no data to support its use in UTIs. Let's move to the next question, please. And it reads, an OBS-GYN resident on call inquires from you as the clinical pharmacist specialist in the infectious diseases team the recommended duration of therapy of pelvic inflammatory disease versus cervicitis in a middle-aged female patient using doxycycline. So my question to you is, which of the regimens listed below would be the most appropriate for this lady? Would it be 100 milligrams of doxycycline twice daily for a week? Would it be the same dose but for 3 to 5 days? Or would it be the same dose but for 2 weeks? Or would you consider a start dose of doxycycline 100 milligrams sufficient? I'll give you 10 seconds to choose the correct answer. So I would choose to manage this case with doxycycline at a dose of 100 milligrams taken orally twice daily for a duration of 14 days. Now the presence of a PID warrants longer treatment compared to cervicitis alone. Remember, cervicitis requires a 7-day duration of treatment because the infection only involves the cervix, whereas a PID requires 14 days because the infection can involve the cervix but is also present higher up in the uterus, which is more alarming or concerning and can put the patient at a risk of developing scarring and an abscess formation that requires surgical drainage. I would just like to remind you that when STDs involving Neisseria gonorrhea and or C. trachomatis aren't treated appropriately, the bacteria can extend outside the uterus and infect the liver capsule, which may result in inflammation and even adhesion of the same, a condition that is called Fitzhugh-Curtis syndrome. It's a very rare complication which causes right upper abdominal quadrant pain where the liver is located. There may also be or there may not be right shoulder pain. There may or may not be coughing due to inflammation of the diaphragm, and ironically, little or no pelvic pain may be noted. I would just like to emphasize that male partners within the last 60 days of such a female with a PID should be offered treatment for obvious reasons, because they may undo the great work you've done of treating her by reinfecting such a lady during unprotected sexual intercourse. Let's move to the next question, please. And the next question reads, Mr. MWO, a 56-year-old male patient, presents to your accident and emergency department with a past medical history of gout, hypertension, and arthritis. His chief complaint today is photophobia and extreme headaches. On physical examination, the physician establishes he has a stiff neck. He has no known drug or food allergies. There is significant concern for bacterial meningitis. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. MWO? Would you settle for cefotaxime and vancomycin? Would you settle for ampicillin and vancomycin? Would you choose ampicillin, cefotaxime, and vancomycin? Or would you settle for D, ampicillin, cefotaxime, and vancomycin? I'll give you 10 seconds to choose the correct regimen. The gentleman is above 50 years of age, so I would settle for ampicillin, cefotaxime, and vancomycin. Remember, the IDSA guidelines for bacterial meningitis state that ampicillin plus a third-generation cephalosporin plus vancomycin is the empiric regimen of choice for bacterial meningitis in patients who are above 50 years of age. Remember, ampicillin is needed as part of the empiric regimen due to Listeria monocytogenes, which is a common pathogen for patients above the age of 50. Now, if Listeria monocytogenes is present, then the duration of ampicillin therapy is 3 weeks, 21 days, and it is dosed in divided doses every 4 hours. I would just like to add a ceftriaxone and cefotaxime are the only third-generation cephalosporins recommended as empiric therapy, since they are most likely to have clinically relevant activity against MDR strep pneumo, unlike the others like cefodoxime and cefixime. I would like to add that ceftazidime has no clinically relevant activities against gram-positive pathogens. Just as a by the way, let's move to the next question, please. Mrs. DKD, a 69-year-old female patient, had a valve transplantation done 40 days ago at your hospital. Today, she presents at your cardiology clinic and her chief complaint is fever, on and off in her own words, general fatigue, and even joint pain. An echo is done and it shows valvular vegetations. A blood culture grows Staphylococcus aureus, and a skin test is done and it reveals oxacillin-resistant Staphylococcus. So my question to you is, which of the therapeutic options or regimens listed below would be the most appropriate for DKD's treatment? Would it be vancomycin for 6 weeks, nafcillin for 6 weeks, or vancomycin for at least 6 weeks plus rifampicin for at least 6 weeks plus gentamicin for 2 weeks, or would you use nafcillin for 6 weeks plus rifampicin for 6 weeks plus at least gentamicin for 2 weeks? I'll give you 10 seconds to choose the correct answer. I would settle for vancomycin for 6 weeks plus rifampicin for 6 weeks plus gentamicin for 2 weeks. Now, due to the high mortality rate associated with Staph aureus PVEs, combination antimicrobial therapy is recommended. Now, for infection caused by MRSA, vancomycin plus rifampicin should be used. Now, the gentamicin should be administered for the first 2 weeks of therapy with vancomycin and rifampicin. And all those many words qualify C as the correct option. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and very kind collaboration, and I look forward to interacting with you in the next video. Thank you.